Treatment of TB is an important topic because there is a lot of changes that has happened so this is going to be the policy for the future of TB treatment in India. Goal of TB treatment: decrease case fatality, that is number of deaths, number of people suffering, by ensuring relapse free cure, minimize and prevent development of drug resistance, render patient non-infectious, by which we should break the chain of transmission and decrease the pool of infection in the country. Regimen is efficacious if it ensures a high and early sputum conversion, high cure rate and least relapse, and long-term follow-up. Long-term follow-up is at least for the 2 years after the last pill consumed for the treatment. Summary of evidences that prompted the changes are: relapse rates. Relapse rates are very high in our country, more than many high burden countries over a period of time in all states. Relapse rates are high with treatment interruption, but not significantly different in patients without treatment interruption. So we cannot blame that because the patients are interrupting treatment, we have a high relapse rate. Relapse rates are high among NSP TB patients in area with no private sector presence. We cannot blame the private sector for their inappropriate regimens resulting in high relapse rates, because this study convincingly proves that even in those areas where there is no private sector, relapse rates are high. Relapse rates are higher with intermittent regimen. They have done a comparative study among those patients who are put on intermittent regimen and daily regimen. So there is a meta-analysis of 47 studies which proves beyond doubt that relapse rates are higher with intermittent regimen, though these patients are less likely to interrupt treatment or they are not likely to last to follow-up also. INH resistance: pre-treatment INH resistance is high, more than 10%. Pre-treatment INH resistance leads to amplification of resistance, acquired rifampicin resistance leading to MDR. Standard 7, treatment for first line regimen. This is the standards that are to be achieved both by the public as well as private sector. The standards for TB care in India, which prescribes that there is a need to give ethambutol in the continuation phase at least for 4 months. Earlier we used to give only H and R in the continuation phase. Extension of continuation phase for 3 to 6 months in special situations like bone joint TB, spinal TB and neurological involvement and neurotuberculosis. Also it advises there is a need to have daily treatment regimen instead of intermittent regimen. It also advises fixed dose combinations. Fixed dose combinations that are very useful. The dosage has been changed now. So instead of thrice weekly regimen, we are adopting daily regimen, 7 days a week, single daily dose, 4 weeks per month. We used to say 6 months of treatment. Instead, we are going to count the treatment duration in weeks. No extension of intensive phase, even if the patient is having sputum positivity at the end of intensive phase, because we have the facility to check whether the patient is having drug resistant TB at the end of intensive phase. For the time being, pediatric patients would continue to be treated with currently available drugs and regimen. Doses in RNTCP daily regimen: 56 doses in IP and 112 doses in continuation phase. That means 8 weeks into 7 days a week and 16 weeks into 7 days a week in continuation phase. The drugs given are HRZE, that means INH, rifampicin, pyrazinamide and ethambutol for 2 months and HRE for 4 months. In those cases who are giving history of previous treatment, 84 doses will be given in IP, that is 12 weeks into 7 days. And in continuation phase, we will be giving 140 doses, that is 20 weeks into 7 days. The drugs given are HRZ and E along with injection streptomycin. So all the 4 drugs that are given in new plus streptomycin will be given for 2 months, and another 1 month HRZD will be given. That means total of IP will be 3 months and HRE will be given for 5 months. CP can be extended by 12 to 24 weeks in certain forms of CNS TB, skeletal TB, disseminated TB based on clinical decision of the treating physician. IP extension is not done even if the sputum is positive at the end of IP. The drug dosages for first line anti-TB drugs are as follows: isoniazid 5 mg per kg in adults, 10 mg in children; rifampicin 10 mg per kg, 15 mg per kg in children; pyrazinamide 25 mg per kg, 30 mg per kg in children; ethambutol 15 mg per kg body weight, 20 mg per kg body weight in children; streptomycin 15 mg per kg body weight in both children as well as adults. Patient aged more than 50 years or weighing less than 50 kg may not tolerate more than 750 milligrams of streptomycin. Hence, those should be calculated and given. So, those patients who are weighing less than 30 kg will also be getting as per the body weight. Daily dose schedule for adults. So weight band, those adult patients who are weighing 25 to 39 kg will get 2 tablets of the fixed drug combination of HRZD, which contains INH 75 mg, rifampicin 150 mg, pyrazinamide 400 mg, ethambutol 275 mg. So in the continuation phase, again 2 tablets of HRE, and in case of those who are previously treated, injection streptomycin will be given as per the body weight, or half gram in 25 to 39, and 40 to 54 kg patients will get 0.75 grams. Maximum dose of streptomycin that is given is 1 gram. Those who are weighing 40 to 54 kg will get 3 tablets in intensive phase and continuation phase. Those weighing 55 to 69 kg, 4 tablets will be there in both intensive phase and continuation phase. Those weighing more than 70 kg, 5 tablets will be given every day. For the pediatric patients, the weight category will change. The HRZ and ethambutol that is given separately in intensive phase, 4 to 7 kg will receive 1 tablet of HRZ containing 50 mg of INH, rifampicin 75 and pyrazinamide 150. So 8 to 11 kg 2 tablets, 12 to 15 kg 3, 16 to 24 4, 25 to 29 3 tablets plus 1 adult tablet, 30 to 39 kg 2 tablets plus 2 adult tablets. Streptomycin also is given as given in the table. Pyridoxine in TB regimen is an important topic because we have a tendency to combine pyridoxine with all anti-TB treatment, which is not at all warranted. TAP pyridoxine is not required for all TB patients. To prevent INH related neuropathy in persons at high risk of vitamin B6 deficiency, that is alcoholics, malnourished persons, diabetics, pregnant women, lactating women, patients with conditions such as chronic renal failure, and those who are HIV infected, these are the patients who should be prioritized. Only they should get pyridoxine. Case definitions: microbiologically confirmed TB, the presumptive TB patient with biological specimen positive for AFB or positive for MTB on culture or positive for TB through quality assured rapid diagnostic molecular tests. Clinically diagnosed TB case: presumptive TB patient who is not microbiologically confirmed but diagnosed with active TB by a clinician on the basis of X-ray, histopathology or clinical signs, with a decision to treat the patient with a full course of anti-TB treatment. In children, this is based on the presence of abnormalities consistent with TB on radiography, history of exposure to an infectious case, evidence of TB infection, positive TST, and clinical findings suggestive of TB in event of negative or unavailable microbiological results. Classification by anatomical site of disease. Pulmonary tuberculosis, any microbiologically confirmed or clinically diagnosed case of TB involving lung parenchyma or tracheobronchial tree. Extrapulmonary tuberculosis or EPTB, any microbiologically confirmed or clinically diagnosed case of TB involving organs other than lungs, example pleura, lymph nodes, intestines, genitourinary tract, joint and bones, meninges of the brain, etc., because the TB can affect any organ except the nails and hair. Miliary TB classified as PTB because there are lesions in the lungs. A patient with both pulmonary and extrapulmonary TB should be classified as a case of PTB. Classification by history of previous TB treatment. New case: a TB patient who has never had treatment for TB or has taken anti-TB drugs for less than 1 month. Previously treated patients have received 1 month or more of anti-TB drugs in the past. So among the previously treated patients, there can be many other types. The recurrent TB case is a TB patient previously declared as successfully treated, cured or treatment completed, and is subsequently found to be microbiologically confirmed TB case. Treatment after failure: those patients who have previously been treated for TB and whose treatment failed at the end of their most recent course of treatment. Failure itself is diagnosed as having sputum positivity at or after 5 months of first line treatment. Treatment after last follow-up: a TB patient previously treated for TB for 1 month or more and was declared last to follow up in their most recent course of treatment and subsequently found microbiologically confirmed TB case. The other previously treated patients are those who have previously been treated for TB but whose outcome after their most recent course of treatment is unknown or undocumented. Transferred in: a TB patient who is received for treatment in a tuberculosis unit after registered for treatment in another TB unit is considered as a case of transferred in. Treatment support program. Record height, weight, BMI of the patient. Look for comorbidities, diabetes, liver or renal disease, neurological disorders, etc., where we have to take the support of the specialist concerned. Substance abuse, especially tobacco in any form, and alcohol. These patients should be offered the necessary help. Open a treatment card. Also must be given a TB ID card. Locally managed additional nutritional support. Public distribution system, Rashtriya Swasthya Bima Yojana, corporate social responsibility wherever it is available should be made use of to support the patient's treatment. Retrieval of treatment interrupters. Screening for adverse reactions, which is a very important component because these are the reasons for the patients to stop treatment in between. Psychosocial support. Comorbidity management is very much required. and follow-up laboratory investigations. Referral for HIV test, and if positive for ART after 2 weeks of ATT and cotrimoxazole preventive therapy. Whenever a patient is diagnosed as HIV positive, they should be given 2 weeks of ATT, then they should be referred for ART, and they should also be put on cotrimoxazole preventive therapy. DOT, directly observed treatment, in all rifampicin throughout regimens, it should be given under direct observation. All the advices, including the STCI, says that rifampicin should not be given without observation, and it is best to promote adherence. Treatment supporter, earlier used to be called as DOT provider, is one who is acceptable, accessible and accountable. A family member can be a treatment supporter in bedridden patient, long day workers and children. So treatment support program, that is DOT provider, will be the one who is monitoring the treatment and will be very helpful for the patient to complete the treatment. So it should be planned by a medical officer and monitored by a health worker. 1/3 of those who are not given treatment under direct observation will stop treatment. This is the NTI study. So they should be monitored. So directly observed treatment is very much necessary. Various information communication technologies, that is ICTs, can be utilized for treatment monitoring. It should be planned by an MO, and we should take the help of health worker to monitor the patient's treatment. Mobility support, if she or he prefers observation of treatment outside his residence. For patients started treatment in private, program can offer such a facility if requested. So many of the private doctors, they may be starting the patients on treatment when they request, or the program itself may go and talk to the private doctors. On request, we can offer the treatment support facility for the patients who are on treatment under private sector. So this is an innovative method, that is 99 dots, where as you see the drugs are there, they are in a strip which is marked. When the patients are started on treatment, like for example as it is projected here, the patient has to take 2 tablets. When the second tablet is taken, these patients, the moment they open the second tablet, they will have a number which should be dialed. Patient will be dialing a number that is given after taking out the second tablet. So it is going to get cut, that is it will become a missed call, and the system, the 99 dots, will record the patient has taken out the tablets. So the assumption is all those patients who are taking out the tablets from the strips are supposed to have consumed in 99 times of the 100. That means, so a pill in hand, that means the patient has taken the tablet. So this is going to be in combination with the patient supporter, that is DOT program, dots and 99 dots. So all the patients who are on treatment will also be registered with their phone numbers. The moment they take out the tablet, they will give a missed call that is there in the strip. The moment they give the missed call, they will be that will be recorded in the 99 dot software. By chance, if the patient has not taken the treatment, immediately the health worker will call up, or there can be an IVRS, so for prompting the patient to take the tablet, reminding the patient to take the tablet. Follow-up of treatment, components of follow-up, clinical follow-up, laboratory follow-up. Clinical follow-up, important for extrapulmonary TB cases, at least monthly the patient has to be followed up. Improvement on chest symptoms, increase in weight, etc. may indicate good prognosis. control of comorbid conditions like HIV and diabetes, symptoms and signs of adverse reactions to drugs should be specifically asked. In case of pulmonary tuberculosis, sputum smear microscopy should be done. At the end of IP, if clinical deterioration, the medical officer may consider repeating sputum smear microscopy even during CP. Chest X-ray can be done when there is a need. At completion of treatment, a sputum smear or a culture should be done for every patient. DST if the patient is found to be sputum smear positive at any time during the treatment. After completion of treatment, the patient should be followed up at the end of 6, 12, 18 and 24 months after the last pill, and appropriate investigation if the patient deteriorates or symptomatic in between also. This is the long-term follow. Usually, what is advised is the specimen that is available at the end of 6, 12 and 18 and 24 months or when the patient becomes symptomatic, better if they are investigated by culture. The highest priority contacts for active screening are persons with symptoms suggestive of tuberculosis, children aged less than 6 years, contacts with known or suspected immunocompromised status, particularly HIV infection, contacts with diabetes mellitus, contacts with other high risks including pregnancy, smokers and alcoholics, contacts of patients with BRTV, household and close contacts, and reverse contact screening in case of children. That means if the patient is a child, we have to screen all those adults who are in contact with the child whether they are suffering from an infectious TB. This is reverse screening. Isoniazid preventive therapy. Children aged less than 6 years who are close contacts or household contacts of a TB patient should be evaluated for active TB by a medical officer or a pediatrician. After excluding active TB, he or she should be given INH preventive therapy irrespective of their BCG or nutritional status. The dose of INH for preventive therapy is 10 mg per kg body weight, administered daily for a minimum of 6 months. The INH tablets should be collected on monthly basis. So there can be a chance that the patient or the child who is supposed to have taken daily treatment for 6 months may have missed the treatment in between, that is the prophylaxis of INH in between, but all the doses they should be able to take completed within the 9 months. So that will be considered as completion of INH prophylaxis. 180 doses should be completed within 9 months. INH preventive therapy in HIV infected children with a known exposure to an infectious TB case or TST is positive. In case of HIV positive, the TST positivity is considered as more than or equal to 5 mm in duration, but active TB disease is ruled out by 4 symptom screening or investigations. All TST positive children who are receiving immunosuppressive therapy, example children with nephrotic syndrome, acute leukemia, etc. A child born to mother who was diagnosed to have TB in pregnancy should receive prophylaxis for 6 months, provided congenital TB has been ruled out. BCG vaccination can be given at birth even if INH preventive therapy is planned. There is no need to postpone BCG vaccination, though there is a chance that INH prophylaxis and BCG vaccination may not go together. Even then, BCG vaccination cannot be postponed because that has to be given. If not given, the child may not be available afterwards, so better to give before the mother gets discharged. Treatment outcomes for drug susceptible TB patients. Cured is the one. Microbiologically confirmed TB patients at the beginning of treatment who is smear or culture negative at the end of complete treatment. Treatment completed, a TB patient who completed treatment without evidence of failure or clinical iteration, but with no record to show that the smear or culture results of biological specimen the last month of treatment was negative. either because the test was not done or because the result is unavailable. Treatment success is not actually an outcome, it is an indicator. It is a combination of the above two outcomes, that is cured or treatment completed. Failure, a TB patient whose biological specimen is positive by smear or culture at the end of treatment. Failure to respond, a case of pediatric TB who fails to have microbiological conversion to negative status or fails to respond clinically or deteriorates after 12 weeks of compliant intensive phase shall be deemed to have failed response provided alternative diagnosis or reasons for non-response have been ruled out. So these are the guidelines for pediatric TB cases given by IAP. Last to follow up, a TB patient whose treatment was interrupted for 1 month or more. Not evaluated, a TB patient for whom no treatment outcome is assigned. This includes former transfer outs. We used to say transfer out, which is a temporary outcome. Now we say it is not evaluated. Treatment regimen changed. A TB patient who is on first line regimen and has been diagnosed as having DRTB and switched to drug resistant TB regimen prior to being declared as failed. Died is a patient who has died during the course of anti-TB treatment. So there is a need for all those who are died during the treatment for death audit to be done by medical officer. In-depth death audit has to be done by the medical officer to ascertain the cause of death. So these are the changes that has happened. So thank you very much.